Hello, everyone. The Maternal and Child Health Student Association welcomes you to Alabama Maternal Mortality Crisis, the role of collaboration and commitment. As we all know, there are many things that contribute to maternal mortality. Today, we are together to hear how the collaboration and commitment of health professionals can have a positive impact. Today's speaker wears many hats, two of which are professor and chair of Department of Health Policy and Organization in the UAB School of Public Health. Please help me welcome Dr. Martha Wingate.
Hi, everyone. I hope you're doing well. I see some new faces and I see some very familiar faces on here that are names that I'm really happy to see on this group. So I appreciate the Maternal and Child Health Student Association for inviting me to do this. And I see we definitely have some other folks on the call here, Carolyn and Amanda, not to call y'all out, but if there's anything that you want to add as I'm going through, by all means, jump in because y'all are experts too. So, and I am pretty relaxed, although in a Zoom setting, it can be a bit tricky, but if you do have questions, I hope that if you're, save them, jot them down, put them in the chat, whatever works for you. So I'm very happy to be here. Just a little bit of background about how I ended up kind of in this space of talking about this. I have worked in the state, worked in the School of Public Health for quite some time, and have worked with our state partners and really kind of started out in the perinatal health side. So was very interested in infants and kind of that birth side of things. But then over the years figured out, hey, wait a minute, moms have to be healthy to have healthy babies. And so transitioned kind of more into expanded actually more into the space of maternal health. And so the place that I'm coming to or coming from tonight is really that of someone who is helping those who are on the front lines, or I hope this is the case, on the front lines doing this work around maternal mortality. Just talking about some of those things, but really I see my role as one of just kind of dot connecting and really thinking about how can we collaborate and really work together to make women and families and communities healthier in Alabama and across the nation, the world, et cetera. But right now, focus specifically on Alabama. So the title was really more to grab your attention, which I hope it did, but I think the second part of collaboration and commitment I think are really important. And just to give you a sense of sort of where all of when we do maternal mortality reviews in our larger groups that we'll get into talking about a bit more, we start with a moment of silence and really remembering that when we're talking about these issues, it's much more about the families and the communities. It's, of course, we're trying to get at the why, but it's really done with in a very respectful manner of recognizing that someone has lost a daughter, someone has lost a mom, someone's lost a wife, a sister, etc. So really trying to bring that to bear that none of this is easy and none of what we're going to talk about is we talk about numbers, we talk about data, but in the end, there's more to it than that. And so, I come to you with that perspective as well, and recognizing that the communities that are the most affected by this are communities at risk. And so how do we kind of bring that health equity lens to this conversation? So with that, I'm going to go ahead and get started. So I want to give a little bit of background about maternal mortality rates and maternal mortality in general in the U.S. and in Alabama, and then want to talk a bit about state maternal mortality review committees. So very broad, we won't get into specifics, but try to walk you through the process of what generally happens and how CDC directs the maternal mortality review committees. And then also to describe how state maternal mortality review committees make recommendations to improve health outcomes. So again, kind of with that end in mind of always trying to think about how do we make improvements? How do we push things forward in terms of improvements? So just a little bit about context. So just to give you some data, and maybe you've seen these slides before, maybe these are new to you, but according to the National Vital Statistics System, which is basically all of the vital statistics information. When I say vital statistics, births, deaths, all of those occurrences are reported to the state, and then the state actually reports that information to the federal system, which is this National Vital Statistics. So according to the data that's moved from Alabama birth and death certificates, if you will, and then to the national level, about 1,200 women died of maternal causes in the U.S. And that's actually we've seen an increase over time. And you can see in those numbers, the bars are a little small, if you will, but you can see that there's a lot of variability, not just over time, but also by race and ethnicity. So in this graph, you have the farthest group of bars are the total. So you see we go from 2018, 17.4 per 100,000 live births to 32.9 100,000 live births. And then you can see that variation by race and ethnicity. So there's a couple of things going on with this increase. Some of it is we've gotten better at capturing the data. So really looking at the death certificates and saying, okay, this actually was a maternal death. And then there's also some issues for those of you that have an interest in epidemiology or have studied epidemiology, the importance of denominators. So when I said the maternal mortality rate, this is actually presenting a ratio. So this is actually the number of maternal deaths as classified up to 42 days after delivery, up to a year after delivery. And this is actually, I believe this is 42 days. These are the data for 42 days after delivery, about 6 weeks. But that denominator is really important. So recognizing that sometimes you could be looking at a rate, which would actually be maternal deaths per women who are of childbearing age or pregnant or whatnot, and that's a little tricky to get. So a lot of times you'll see maternal mortality rates reported as truly ratios over live birth. So that's just an easier way to capture that information, just because of the way our data are available, if that makes sense. So that's the nerdy data part of that, but it's really an important, if you're looking at the data, that's actually a really important thing to pay attention to, because sometimes you do have the potential to compare apples to oranges, if you will. So in some cases, you'll see information that's death up to 42 days, maternal deaths up to 42 days, or you can talk about maternal mortality up to a year. So there's some variation, and then there's pregnancy-related mortality. There's a lot of different ways to define, but just kind of keep in the back of your mind that definition is really important. I teach an entire class on these topics, so I'll try not to go too nerdy on you on that and get to the meat of this. So again, according to the National Center for Health Statistics, Alabama actually demonstrated a maternal mortality rate of 41.4 deaths per 1,000 live births between 2018 and 2021. And Alabama ranks as the fourth highest having the fourth highest maternal mortality rate in the nation. And I've given links here if you're interested in looking at those particular data. And so, again, we have Alabama specific data that's reported to CDC, National Center for Health Statistics, But that's kind of the number that is used in that national reporting piece. So now I'm going to shift gears a little bit and talk about what is a maternal mortality review committee. So there's a couple of different things that you probably want to know about how we capture information on maternal mortality. So we have the death certificates. There's a check box actually on the death certificate that ask about pregnancy. Sometimes, if you think about it, sometimes someone would, person who, say if it's a death that occurs close to a delivery, that checkbox would be pretty easy to know to check. But then in other cases, it might be a little harder. So there's a lot of kind of nuances as to how the data are collected and what that really looks like. So again, big picture, you know, we're trying to get the best snapshot and the best information that we possibly can. And so I'll get into that idea of collaboration and commitment and really thinking about that big picture system and why that's important. So a maternal mortality review committee, this is actually the multidisciplinary. And when I say multidisciplinary, there's on Alabama's committee, we have everything from there are folks on there like me who have no clinical background. I know enough to be dangerous, literally, to folks who actually conduct autopsies and have conducted autopsies around some of the cases that we review. So there's a lot of variability, but it's really, and that multidisciplinary approach really brings, I think, a richness to the conversation around kind of this puzzle that you're trying to put together, if you will. So these committees come together, and ours is at the state level. Some states have different committees that review different types of deaths, et cetera, or they have committees that meet to review, certain time. It varies across states, as we know that public health does. But we have access to clinical, non-clinical information, so information around medical records and social service records. So really the idea is to dig into that, and it's not to point fingers or to blame anyone, and it's not to kind of examine, oh, well, the doctor should have given this medication instead of that medication or anything like that. There's nothing going on in that space, but it's really just to look at and say, how can we do this better? How can we really think about making sure that the things that we have in place, either on the individual, if you think about the social determinants of health, or you think about the social ecological model, what are those things that we can put into place on the individual, the provider, the community, and the systems level and policy level? What things can we put into place, or if these things had been in place, what could have been improved? So it's really trying to focus on prevention, and that's the key. And this is all the MMRCs are really guided by CDC and by the work that's done there, because the data actually go back to CDC through a form that I'll show you in just a minute. So here's 7. I don't know if I can make that disappear or not, but oops, I'll go back here. So, 7 things to really know about maternal mortality surveillance and maternal mortality review committees. So there's 2 sources for national estimates. We have the National Center for Health Statistics, and then also the pregnancy mortality surveillance system. And both of those are administered by CDC, and those produce our national estimates. So again, we're trying to get the best information we can, casting the widest net, but at the same time, making sure that the data are good and provide us with that information. And sometimes, and I've heard some of our colleagues from ADPH, Alabama Department of Health, say this, that sometimes the information or the data that comes from the state And then the information that's coming from the national levels, those will look different. And again, this is really talking about numerators, definitions, all those things that I mentioned earlier. So again, kind of giving you a bit more information from that side. And MMRCs are the best way to count and to understand maternal mortality. I think we all recognize that there's probably cases that we're going to miss because a box wasn't checked, somebody didn't know that somebody was pregnant, but thinking about how we can do the best we can to think about those big picture kind of, okay, if there are themes that we see, if you will. So thinking about themes around if there's issues around substance use disorder, that we're seeing themes across the cases there. If we're seeing themes with cardiac issues or chronic conditions not being treated. So there's a lot of different ways to kind of think about how that this process works. So it's counting, but it's also understanding, which is those are a little bit trying to mesh that it's not going to be a perfect, you're not going to have all the database isn't going to be perfect, all the information isn't going to be perfect, but we're trying to get at that understanding. It's a process and a committee of individuals. So again, it's that idea of really, I'll get to the cycle in a minute, but it's a cyclical process that it's about action and kind of moving the recommendations forward. And, MMRCs operate at the state level. Sometimes there's larger city level, I believe, if I'm not mistaken, Chicago and maybe New York have city MMRCs. I could be wrong on the New York one, but I'm pretty sure there's some of the larger cities will actually have review teams for that. And we've seen a huge a doubling of MMRCs in the last 5, 7, 8 years, just because of the recognition. And there have been quite a few legislative efforts that have come nationally to fund agencies and to provide assistance. So here's the really, when we look at our action cycle, we identify cases, we think about the case selection, case abstraction, and there's a team of abstractors at Alabama Department of Public Health that do a fantastic job of digging, asking, looking at medical records, trying to get as much information as they possibly can to pull together to give a picture of what led up to and what happened after, or what the events were surrounding a maternal mortality case. And then that case abstraction is taken to case review. So there's a group of in Alabama, there's a group of folks that get together quarterly, review the cases as they're available with as much or as little information as is available, and then move into the reporting. And then that reporting is released to the public. And then you see the cycle start to repeat. And that release and beyond is really okay, what's the next step? What are we going to do about it? So hopefully hopefully that makes sense. And I meant to mention this earlier, but there's a very similar review process that happens for infants and fetal deaths as well. So the processes are similar. They're not identical by any stretch, but the idea is really the same of what changes can we make to make improvements in both maternal and fetal and infant mortality, as well as maternal. So the review process for Alabama, so a maternal death case is identified. As I mentioned, the team of abstractors conduct their investigation. They may have the opportunity to talk to families. They may have the opportunity to talk to law enforcement, a number of different resources. And they actually summarize the clinical information and the social history leading up to the death. So again, it's that trying to get as big of a picture on all levels of social determinants as possible. So it's not just about the clinical perspective, but really that big picture public health lens of what's going on. Committee members review the cases. And then there's a Maria form, which I know that doesn't look like Maria, but that's what it is, the MMRIA form, which you'll see that in a minute. That is a standardized form that all MMRCs use, and that information goes back to CDC. And that we actually are given kind of guidance on how to think through and report on the information from the cases. And then committee members determine the level of preventability, which is that's an interesting conversation. And then they make recommendations. And then ADPH submits the Maria forms to CDC for that final kind of gathering together of information. So I mentioned some of the data sources here: death certificates, of course, autopsy reports, birth and fetal death certificates, if possible, prenatal care records, law enforcement, and you can see anything that is helpful in understanding more about the circumstances surrounding, again, individual, system level, and everything in between. That abstraction team tries to get that information. And you can see here, there are individuals from these organizations and then these special areas that, so this kind of runs the gamut of information. There's community members and those with lived experiences. There's folks that come to the table that have health equity expertise. So really trying to make sure that it's a broad brush of vantage points, so that if I'm thinking in my very, very, very big picture brain about prevention, that kind of marries with maybe someone else's idea of prevention that looks different than mine. And so how that all comes together is actually really quite interesting, and again, done in a very respectful and meaningful way. So there's a lot of conversation, time taken to have these conversations. So this is the Maria form. So literally we go case by case with the deaths and actually look at pregnancy relatedness. So you can see, again, this is all about definitions. A death during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by physiological effects of pregnancy. So that's okay, delivery, and then, mom ended up having a pulmonary embolism because of something related to, within a certain amount of time. Pregnancy associated but not related, that's where a death occurred during pregnancy or within 1 year of the end of pregnancy from a cause not related to a pregnancy. So something like a motor vehicle accident. And then that third category is when we can't tell. You think, okay, well, maybe it could have been, yes, she was pregnant within that year's time, but not sure if the death was or wasn't related. We just can't tell. So those are sort of the ways that things break down. And then you have information on the degree of completeness of the case. And then we work through if the death is determined to be pregnancy related, we talk about the cause of death. And that's actually a really interesting conversation in terms of what's on the death certificate. So really looking at that and then reading the case and hearing, most of the time, a lot of that conversation is from a clinical standpoint, but saying, well, was that really the cause, the underlying cause? What were the contributors? So kind of gets into that, if there's an autopsy, that actually is incredibly helpful, but only about half of our cases actually have autopsies. And so really trying to figure that out. So there's opportunities there. And then you can see, thinking about things like obesity, discrimination, mental health conditions, and substance use disorder. Manner of death, again, just kind of looking at how those come to bear. So you can see here when they actually give guidance on, well, here's the is the death preventable? Yes or no? Is there a good chance? Some chance, no chance. Again, there's discussion of, in my mind, I might say absolutely there was a chance, because if someone had, if way before the pregnancy, if this person's chronic condition had been under control, they would have had a very good chance of survival, whereas somebody else might look at it slightly different. So kind of coming to that consensus is really important. The contributing factors, you can see there's a number of definitions here, and I won't go into that, but really this helps us think through what's the so what are the levels that we can try to impact by making these recommendations. So if it's a big policy recommendation like Medicaid expansion, like trying to think of other examples. Medicaid expansion is the big one that comes to my brain right now. So there's a lot of different ways that you can think about these, but really that this kind of guides us. And you can see the ICD-10 codes that are used, and then contributing factor description. So when we actually look at something like structural racism, for example, there's a definition, which sometimes these are, kind of reading between the lines of the case to say, okay, maybe this was that. But again, I think it's not meant to be punitive. It's really meant to say, hey, this is something that we should consider, and because we know we can do better, and how do those pieces fit together. So a little bit on the MMRC report from Alabama. So during 2019 and 2020, the Alabama MMRC reviewed 80 maternal deaths that occurred during pregnancy or within 1 year, and during the years 2016 and 2017. As you can imagine, it takes time to gather all this information. So it's not an automatic, we're not in 2023 reviewing cases from 2023. It just takes some time to get all those, the data that go into this aligned. So looking at from this 2020 report, which is actually the 16 and 17 maternal deaths, 8 out of 10 deaths occurred 6 weeks after delivery. So after that postpartum visit, that first postpartum visit, most of the deaths occurred kind of in that space. And we actually, we had a special session to review COVID-19 cases. So those have been reviewed and are taken into account. So you can see, looking at the timing of death, we have the total. You have pregnant at the time of death, about 9% died within 42 days of postpartum. That's 6 weeks. We had about a third, and then you had over half that died after. So, and that's pregnancy associated is the biggest. And then you can see really that pregnancy related, and pregnancy related was that thinking that it's or believing that it's directly related to the pregnancy, about 63%. So I think that dying within the 42 days postpartum, thinking about the potential systems improvements that could be made around that. And all of this information is actually available in the Alabama MMRC report. So I've just pulled out pieces just to give you a little bit more information. So our leading causes, primary causes of death, were cardiovascular related events, substance use, and infection. And about 50, as I mentioned earlier, about 50% of the deaths reviewed had documented autopsies. And that's kind of an interesting conversation of, our families Do they want to have autopsies? Are they asked? So there's a lot of different things that come into play that I know that there's a number of agencies that are working together to try to increase that so that we have more information, certainly, but also, again, doing it in a respectful way for families that is appropriate. And it was determined that more than 55% of the deaths were preventable, which is pretty staggering when you get down to it. And more than 75% of deaths identified as preventable had factors that could have been modified. So pre-existing chronic conditions, substance use disorder, limited consistent access to care. So, again, thinking about in Alabama, you have, without Medicaid expansion, although we do have Medicaid extension. So starting, I believe, last fall, women who had SOBRA Medicaid, which is the pregnancy Medicaid, instead of Medicaid ending 6 weeks after pregnancy, which is about that 42 days, the Medicaid eligibility was extended to a year. So that gives time for those things that might show up afterwards, et cetera. One of the challenges still, without that expansion of Medicaid to include pre-pregnancy women who haven't been pregnant before, there's chronic conditions, there's all kinds of things that you can't fix as you can't fix something in 9 months. If you're pregnant and you have diabetes, hypertension, et cetera, fixing that through things like prenatal care, et cetera, is not really possible. So the idea of preconception and interconception care is really important. So that's where some of these conversations around policies come into play. And you can see, again, demographics. So comparing the cases to the live births in Alabama, they're more likely to be, you have a higher proportion of cases that were reviewed, slightly higher non-Hispanic Blacks versus the live births. But again, non-Hispanic whites are about 60% of births and about 55% of the cases reviewed. So you can kind of see that there is variability there. So payment source, you can see that about half of deliveries are Medicaid deliveries, but then about 67%, 68% of the cases reviewed were Medicaid, were on Medicaid. So some variation there to think about. There are, about there's more women that don't have prenatal care that are part of the case reviews, unfortunately. And again, kind of thinking about that continuum of care and what that looks like. And documented, we do have a number of women that have documented pre-existing conditions that we see as part of these deaths. So when you look at contributing factors, so what happened around the death? Delay in referral or access to care. Substance use disorder is one that we see quite often. Limited knowledge or understanding related to significance of health events. So if someone has a chronic condition that maybe they needed to be under the guidance of a physician before and during their pregnancy, but they just maybe didn't know about it and what are the implications there. And also there's adherence to medical recommendations, and a lot of time we don't know the motivation, of course, but it's not taking certain medications, taking yourself off certain medicines. So there's a lot of variation in those individual level factors. And again, the idea is not pointing fingers or placing blame. It's really trying to say, how do we help educate people to make sure that we can do this better? And then provider level factors, certainly thinking again, if you think about social determinants of health and you think about kind of your inner circle to your larger circles, if you will, I should do it this way so that y'all can actually see how my hands are moving. We have provider level factors, knowledge related to care or evaluation. We have some very strong, good hospitals in the state. Unfortunately, sometimes needs of the patient and the hospital don't always match, and that is it's geography. There's a lot of different things. So that idea of how do you get people to the right place and do that in a timely manner, and it's getting harder. If y'all have seen the news lately, made national news about three delivery hospitals closing in the state. So there are challenges with that. And that, of course, goes with this provider, because if you have, 1 to 2 deliveries a month versus, 4 to 5 every day, there's some variability there about knowledge and how you deal with certain situations. Lack of referral to needed services or consultation, just maybe not understanding the need to bring in a specialist or the need to consult on something. So, and not asking questions. And again, not pointing blame, because we all know that, going into a provider is hard because time is limited. So how do we really make the most of that and that education and those clinical skills? Systems level factors, these are the ones that I'm usually on, if you will, in terms of recommendations and whatnot. Lack of access, financial resources, certainly poor communication between systems. You might have situations where you have an OB patient and you have somebody who has a mental health issue, and those two systems don't always connect. Limited continuity of care, lack of standardized policies and procedures. That kind of goes sort of with the provider, but really, if you think about that on the hospital level as well. And then this is a huge one, limited resources related to substance use disorders. And we've talked often about, shouldn't we screen everyone for substance use disorders? Well, the challenge with that is we don't have ways to treat them. If we identify people with these issues, what are we going to do? Because once you screen, you have an obligation to do something. And how does that work? And so in a resource limited state, that's a big challenge. And then also there's issues around criminalization that come into play as well. And if y'all want to ask more about the criminalization, happy to do it. So this is the PDF, the link to the PDF for the 2020 report that I referenced. But I want to go through some of the recommendations that I talked about. They go hand in hand to some extent with the contributing factors. And I'm going to take just a second to look at my perfect. I see one question that I can answer. Lavinia, I teach a class on this topic, and I'm happy to talk with you more about it as well. Now going back to what I was saying, sorry about that, but recommendations, when we talk about patients and families, again, a lot of this is education. One of the things that we're doing through one of our grants, through our maternal health initiative, which is the Alabama Maternal Health Task Force, is buying wristbands for women who have been pregnant, so that if something happens, they have a wristband on, like the plastic kind of rubbery wristbands, that it just helps identify, hey, if something happens, I'm in a area where, it just lets providers know, hey, this person has been pregnant recently. you hear there's all kinds of anecdotal stories that I'm sure if you have an interest in this topic that you've heard of in terms of, well, I was swelling. I felt funny. My vision was weird. I didn't get it checked out. So the idea of education and empowerment. If something feels weird, go to the doctor, period. And then there's there's a number of things that go into that in terms of our response, and our opportunities for improvement on response related to structural racism and bias, et cetera. So these are all topics within topics, but with providers thinking about proper screenings for conditions, again, it's kind of that balance between we want to screen for things, but at the same time, how do we balance that with, if we screen for substance use disorder, for example, depending upon where we are, who we're screening, and what resources are available, it gets tricky. But that idea of how do we make sure that providers are educated, it may not be just on substance use disorder, but on other conditions to be screened for. Contraception is a big one. Pregnancy interval is a very important topic that I think we sometimes overlook. But having one pregnancy right after the other, that's hard on a body. So that idea of how do we make sure that women are as healthy as possible before they get pregnant, regardless of whether they've had a pregnancy prior. Evidence-based protocols, again, getting in as we have hospital closures across the state, how do we make sure that providers are given the tools that they need for these conditions, and how do we make sure that the hospitals have those as well? Facilities, thinking about social services, a lot of that is dot connecting. So, making sure that those social service needs are met. Transportation is a big one that we see, and that's a challenge. Protocol management for patient flow and conditions. So are people getting to the right place in the right time? Access to services and quality care certainly is another one. And when we look at communities, public health partnerships, community support programs are incredibly important. And at the systems and state level, one of the big things that has been talked about is the maternal levels of care. Right now, we have a system to where babies can be taken to the right level NICU, if you will. So if a baby is delivered in a smaller level, in a lower level hospital, a hospital that doesn't have a NICU, they can be transported to one of the higher level hospitals that has a NICU, but that doesn't happen for moms necessarily. We try to do it in a way that, okay, if someone is identified as high risk, getting her to the appropriate maternal fetal medicine specialist, et cetera. But that structured system is something that's being worked on. Data collection is certainly another one. I've mentioned the autopsies. There's things going on that you can read about in the MMRC report that trying to improve that to have a better understanding of the true causes of death. And then also Medicaid expansion that I mentioned earlier, not just, the extension is fantastic, but really, thinking about that interconception and preconception care is very important. And also that one of the other things that I think we sometimes leave out is the family and education of the partner, spouse, family, et cetera, on how all of this works too, because it can be overwhelming, as you all probably know. Also,
we do have a question. How will Medicaid expansion help, since pregnant women get automatic enrollment into Medicaid?
Yes, they do. So I think with expansion, if you think about how expansion works, it raises the bar in terms of eligibility for regular Medicaid, which would be the prevention. So, with sober Medicaid, which is the pregnancy Medicaid, I think in Alabama it goes up to 133% of the federal poverty level. I think that's where we are right now. So the idea is if we were able to increase that, but let me back up. Without being pregnant, I think we're down like at 50% of the federal poverty level for regular Medicaid. So just being able to go to the doctor for preventive visits, et cetera, getting your regular care. And so the idea with expansion is you'd still have the pregnancy coverage, but it would expand the pool of those women who would be on Medicaid regardless of whether or not they were pregnant. That was a long way to answer your question, Emos. It would just expand the pool of women who had access to being able to manage diabetes, hypertension that existed without pregnancy.
I was going to say too, because I may be reading too deeply into your question, and Carolyn's a better Medicaid expert than I am, but not all pregnant women are automatically on Medicaid. So it's just as Martha explained, you've got to meet a certain income requirement. So without Medicaid expansion in general for any population, we have a lot of adults that are at a certain level that just do not qualify for insurance at all. So do not qualify for Medicaid, which, maybe the lower income coverage, and then can't afford marketplace insurance. And so I may be reading a little too deeply into your question. But expansion would be huge, and that we could open coverage for a lot more adults in the state.
Thank you, Amanda.
And I can't stress enough, this is Carolyn, I can't stress enough how many women are coming into pregnancy with chronic conditions that could have been addressed. And Martha, you touched on that, but a large majority of the women that we see don't have insurance when they become pregnant. And so they aren't addressing all of those chronic conditions that result in the maternal mortality and the maternal deaths.
They may have had, when they were under the age of 18, they may have had good coverage through Medicaid or through All Kids or whatnot for a chronic condition, say a heart condition. But once they age out of that, they don't have coverage anymore. And then the next time they enter the system is when they're pregnant, to Amanda and Carolyn's point. So it gets really tricky. There's a few programs that are being worked on right now to expand coverage to like covering I'm not 6:30 is late for me to be talking to anyone other than my family. So I'm getting there, but so forgive me, but the idea of covering the fetus. So you're covering the baby during pregnancy, but you're really covering the mom for women who don't have insurance, et cetera. So there's some pilot programs that are going on across the state with that right now. So, and I think that's expanding soon. Is that right, Amanda? Or is it in the midst of expanding? Yeah.
It's expanded from 3 counties to 36, either as of May 1 or June 1, but it was the summer. Right. As far as all babies goes, yes.
All babies, yes. Great. Thank you.
And it is
hopefully.
Oh, go ahead.
No, go ahead.
It's going to be a little different in that it's, as you mentioned, it's really about the baby. And so the postpartum care is full care, but it's only 60 days post-delivery date. So it is not exactly like Medicaid.
Right. Yeah. Thank you for that. Enos, hopefully that answered your question to some at the practice program level. Yeah.
We had another question come in. Since the Maternal Review Committee is conducted on the state level, does the local health department do any kind of data review on their part?
Carolyn, you
I can answer that. Yeah, we've got it on the regional level. We are reviewing all infant deaths and most fetal deaths. We're one of the few states in the nation that actually cover the entire state when it comes to fetal and infant deaths, which are related to maternal health. But we also have people from all over the state who are on the MMRCs, and that includes our regional nurses that look at the infant deaths, as well as those community agencies. But the the initial reviews are at the state level, but they are reaching out to the communities for abstracting those cases. So they're reaching out to the local communities. DHR was involved. They're reaching out to them, the law enforcement, and so many different people at the community level as they are reviewing those records.
Yeah, and like as I mentioned, the FEMOR, which is fetal infant mortality review, is similar to the MMRC, but that state and regional approach is certainly important to note. And I think there's really two teams. There's the case review team that actually does what I've described to for the most part with the MMRC, and then there's the community action team, which is sort of that next step policy review. But there have been I actually sit on our regional team for FEMOR, and kind of thinking to myself, although I've said it out loud a number of times, and I think Carolyn's probably heard me say it, but the idea of that continuum, that some of the maternal deaths that we see, how does that affect the fetal, the infant, and sort of thinking through all of those pieces. And I know that that's on everybody's radar, but it's really just offer the capacity to think through those things is important. Hardworking folks on all of these that make all these things go.
We still have a couple more minutes where we can take some additional questions. I will ask this. The Maternal and Child Health Student Association recently decided that they would try to get all their business done in the first half of their hourly monthly meetings. And then for the second half of the hour, they would discuss a maternal and child health topic. And one of the ideas we had was, in the meeting following a seminar, we would discuss the topic that was covered in the most recent seminar. And so if you knew that we were going to get together for 30 minutes and discuss the MMRC or discuss maternal mortality in general for Alabama, are there some things that you would suggest that we talk about, or some seed questions that you would suggest that we put out there to get people thinking or talking?
I probably have thoughts, but I'd love to hear from this group what piqued your interest. I gave you a lot of information, and it probably, as I was going through it, I'm interested in it. I hope that came across, and it wasn't too didn't lull you to sleep. But I think there's so many nuances, so I'd be interested to know if you all had top things that popped up as I was talking. Don't you love that, Julie? You ask me a question, I ask a question back.
And it's not necessarily, I realized as I was asking it was kind of unfair to ask.
No, it's fine. I mean, I could give you, these are, in all honesty, some of you are familiar with the maternal health task force and with the Alabama Perinatal Quality Collaborative, but honestly, these are questions that the questions that you ask, those are things that we kind of wrestle with as a project team on a day-to-day basis. What's the right we talk with hospitals about what's the right protocol or what's the right quality improvement project to put into place. Right now we have we're going to be doing one on babies with hypothermia, and then maternal hemorrhage, and so I think a lot of there's a lot of questions that I think are going around right now. So, trying to figure out the pieces of the system that are working well and those that aren't working well. How do we do that? How do we think about, I was looking at something the other day with, if y'all have seen the maternity care, March of Dimes maternity care desert report. I was looking at some data on, the proportion of deliveries that are actually in the counties that don't have delivering hospitals. it's pretty small when you get down to it. So kind of thinking about that, wrestling with that idea of, well, what do you do with that? If there's not very many deliveries in a county where there's a hospital, but they don't have much business, how do you kind of reconcile that from a business standpoint? So I think there's a lot of different questions, that you can take. And I think the other thing that we think about is who's not at the table. What questions are we not asking? We had an aha moment a few weeks ago that, we were talking about, well, we should do this, this, and this. And it was like, and I was sitting at my computer and I was like, well, what do women really want? For those of you who have never seen the movie, there's a Mel Gibson movie, What Do Women Want? And I started doing a lit review search. What do women want during pregnancy? And so the idea is we're going to ask. We're going to go into communities with our community engagement team and ask what is it that you want? Do you want doulas? Do you want nurse practitioners? Do you want what are the things that you want and that you need? And really trying to dig into that space. So that was not really an answer. That was more me talking, but but if you have any ideas, I'm all open. So, yeah. Or if things come out of your conversation, let me know.
Yeah, it gave me some ideas for some seed questions. If you're a student on tonight's seminar and you're not a member of the MCHSA and you want to know more, just go to our UAB Engage page. That's like our organizational website. We're a registered student organization. We learn all about what we do. You can see links to past archived seminars. So thank you everybody for participating tonight, and I hope you have a good rest of the evening. And Martha, thank you very much for this information. It's been really timely and really interesting.
Thank you. Y'all have a great night. Bye-bye.